Welcome everyone to our DBS Ambassadors Educational event. My name is Jackie Forbes. I'm a coordinator for our Parkinson's Foundation Center of Excellence, and I'm going to be helping moderate the event today. If you do have any questions throughout the speaker presentations or for our ambassadors who were nice enough to join us today, please put them in either the chat or the Q&A boxes that should be located at the bottom of your screen. We are going to be hearing from representatives from our BIDMC neurology department as well as neurosurgery, and then we have 3 ambassadors who underwent the DBS workup process and surgery at Beth Israel, and you'll be able to ask them any questions that you may have. The first half of this meeting is going to be recorded, and we'll send that out after if you'd like to rewatch and see any of the slides for a second time. To begin, we're going to hear from Dr. Lon Lowe. Dr. Lowe is a neurologist in our Movement Disorders Division and medical director of our DBS program. She joined us after her fellowship in epidemiology training at Columbia University Medical Center. Prior to that, she completed medical school and adult neurology residency at Baylor College of Medicine. So with that being said, I'm going to have Dr. Lowe go ahead and start with her presentation.
Hi, everyone. Thank you for that introduction, Jackie. So I appreciate you all being here today. I also want to thank especially our 3 DBS ambassadors for giving their time to be with us today to give their perspective about deep brain stimulation. I want to first in this first 10 minutes to give a brief overview of what deep brain stimulation is, and then followed by what we look for clinically as far as the indicators of when we would refer patients for DBS and when you would may find yourself to be an appropriate candidate for getting DBS surgery. Okay, here are my disclosures and conflicts of interest. I am one of the site PIs for the Abbott DBS adjoint and Rome study, which is currently ongoing. I'm also one of the site PIs for the Neuroderm subcutaneous infusion of levodopa. I'm also on the advisory board for Mitsubishi Tanabe Pharma America and the Fortis Medical Device Limited company. But these actually do not have any pertinence to my discussion today. This is a schematic of deep brain stimulation. So this shows these 2 thin pieces of wire that are inserted into the specific target in the brain. And then this thin piece of wire is then connected by what's called an extension cable that is placed underneath the skin of the scalp and then the neck, which is then tunneled finally to what you see there in the chest. That's called the implantable pulse generator, which is otherwise known as the battery pack. The battery pack actually powers the DBS device, and the IPG comes in 2 different types. One is a rechargeable device, one is a non-rechargeable device. I'll get into the differences a little bit later in my talk. There are, for Parkinson's, there are 2 targets which are potentially choices of implantation. One is called the subthalamic nucleus, otherwise known as STN. The other placement or the target could be something called globus pallidus interna, that's abbreviated GPI. For the case of essential tremor, the target in the brain is called the ventral intermediate nucleus of the thalamus, or VIM. And then for the indication of a diagnosis of dystonia, the target is the GPI as well. So I want to talk about some clinical factors that is setting up for eventually the success of the DBS outcomes. One is a selection of the appropriate patients at the appropriate clinical window. So, for example, patients with Parkinson's disease having had this disorder for at least 4 years could make someone a potentially good candidate for DBS. In cases of dystonia and essential tremor, it's more people that are refractory to medications and they're not getting great effects from the typical medications. And then reasonable expectations, of course, having after surgery. This is actually just making sure you have appropriate mindset about what DBS can and cannot achieve. Accurate electrode placement is very important. And here at BI, we're thankful to have Doctors Ron Alterman and Joshua Aronson, who are our functional neurosurgeons that help us with the appropriate and accurate electrode placement. And then careful DBS programming and long-term follow-up are the other portions of this algorithm. So the realistic expectations, what I mentioned before, DBS is not considered, it's not a cure for any of these conditions, but it is a good treatment for a lot of motor symptom for movement disorders. For example, some of the motor symptoms that can be alleviated include tremors, dyskinesias, which is a fidgety movements of the body that can be a result of taking dopaminergic medications, dystonia, which is a medical term for abnormal posturing of one part of the body, motor fluctuations. This is pertaining to Parkinson's disease, the ups and downs when the medications is working versus the downtime when the medication has worn off. And slowness and stiffness are the other considerations for getting DBS. And DBS does not slow down disease progression. And then the other consideration to keep in mind is that it takes some time to achieve the optimal results. When you get DBS surgery, you should not expect that you will be absolutely without symptoms right after the surgery, but actually we turn the device on at about 3 to 4 weeks after brain surgery. And then the tweaking of the settings, this takes actually about maybe 3 to 4 months, 3 to 6 months in the terms of Parkinson's disease, and then maybe a bit longer to get to the optimal results for cases of dystonia. So discontinuation of medication is another topic that people are concerned about. Are people able to reduce dopaminergic medications after they get DBS? While this may be the major concern for some patients, this would depend on your own clinical situation. And then in cases of what I mentioned, this STN target or subthalamic nucleus DBS, this will give you the best chance of medication reduction after your surgery. If you have the other target, the globus pallidus interna or GPI, the reduction in medications may not be as much or at all after surgery. So Parkinson's disease, which is one of the major indications of getting DBS, what are the typical symptoms that a patient may see improve after surgery? So this is again with the optimal DBS setting, the tremor, slowness, stiffness, the wearing off episodes and motor fluctuations, as well as the uncontrolled involuntary movements of the limb. These are potentially symptoms that can be addressed. Other symptoms that are usually not changed by DBS, those include freezing of gait, poor balance, memory and cognitive problems, hallucination, psychosis, having a soft voice or difficulty swallowing, drooling or bowel or bladder issues. These are typical symptoms that we usually do not expect to see much change after DBS. And the other indications for DBS surgery included this condition called essential tremor. This is a separate condition from Parkinson's disease. And I mentioned the target here is VIM. And in terms of symptoms that will most likely improve with DBS, these include the action postural tremors in the limbs, Sometimes a head tremor will be there, and that can also improve after the optimal stimulation has been achieved. And then items or symptoms that are typically not changed include voice tremors, balance, memory, or cognitive problems, and hearing loss. So I place hearing loss on here is because actually there is an increased risk of developing hearing loss with diagnosis of essential tremor. So that's why this symptom is included on this slide. And sometimes people may be curious about the diagnosis of hearing loss. And then the third indication that I mentioned before is something called dystonia. Dystonia is an abnormal posturing of a particular part of the body that can involve, for example, curling of the toes. Sometimes it may be a particular posturing of the head and neck. This is or described as excessive pulling of the muscles, maintaining an abnormal position or posture, and it can be associated with pain as well. So the candidates here for DBS include those with a primary idiopathic dystonia, certain genetic forms of dystonia, for example, a DYT1 mutation, or potentially drug-induced dystonia. There are certain types of dystonia that may not improve with DBS, and that includes people who have what's called secondary forms of dystonia. So, for example, there are sometimes dystonia that's involved with other injuries, for example, head injuries, or perhaps from other factors, and those may not have as much of a effect after surgery. So we, with approach to DBS evaluation, most or probably all centers in the US will do a multidisciplinary approach. What that means is that you get evaluated by multiple clinicians with different expertise, and that includes movement disorder specialists. In the case of BI, we have, besides myself, there's Dr. David Simon, Dr. Ludi Shi, Dr. Shabir Merchant, as well as our nurse practitioner, Quinn Nguyen, who can do a DBS evaluation. Our functional neurosurgeons include Doctors Ron Alterman and Dr. Joshua Aronson. Our neuropsychologists, they perform a baseline cognitive evaluation, which is about a 3 hour of a memory and cognitive testing prior to DBS surgery. And then the other specialists include a speech therapist, social worker, and psychiatrist. And these are optional and will depend on the particular clinical scenario of the patient itself. So when I've been mentioning something about DBS programming visits, and you may ask what exactly is going to occur during that time. So programming visits are when you come into the movement disorder clinic, and the first visit happens about 3 to 4 weeks after your brain surgery. This is when it's about 1 to 1.5 hours in duration. And for cases of Parkinson's disease, this is done typically while holding your dopaminergic medications, for example, holding it for about 12 hours before you come into the clinic. At that time, we will check the incision sites and also check all the electrode and the contacts, as well as doing a procedure in which we increase the stimulation that's delivered in a stepwise fashion until the motor benefits are seen, or if potentially if there are any side effects observed. We will record the observations and then determine what is the best contact for you to be on. And these type of programming and visits usually happen in monthly succession. So you will typically get about 6 visits after your surgery. So the first one being about a month afterwards from your brain surgery. So in terms of these programming visits, what exactly can be adjusted? So there are three major parameters that can be changed, with the first one being amplitude, and that means the intensity of the DBS stimulation that is delivered. Changes in amplitude probably make the most uh, they contribute the most to the stimulation that's being delivered. Pulse width and the rate or the frequency are the other parameters that can be changed. For example, pulse width is the duration of each electrical impulse that's being delivered, while the rate or the frequency is indicating the number of pulses of stimulation that's delivered per second. I also talked about these follow-up DBS programming visits. Those occur on the monthly basis. Like I mentioned, those will be 5 visits after the initial programming visit for a total of six visits after your brain surgery. And again, this is about tweaking the settings slowly over time. We adjust those according to the setting that's giving you the most benefit while avoiding potentially DBS side effects. These can take up to about 6 to 12 months in order for us to find that appropriate sweet spot or the appropriate setting for you. So I've gotten some other questions in clinic regarding what are the advances in DBS technology. So in the past few years, there's something called directional stimulation. Actually, all three DBS manufacturers, including Abbott, Medtronic, and Boston Scientific, have this directional DBS lead. And that just indicates that there are some segments within the lead that is segmented, or it's divided into thirds. So on the top graph there in the picture, you see a picture of a monopolar or a non-directional contact, in which whenever you turn up stimulation, it's delivering the stimulation almost like a sphere, and it's 360 degrees all the way around. However, in the bottom picture, you see that this is with the directional stimulation, you can deliver the stimulation into a particular place within that segment. So, for example, if you have the green area being a sweet spot where you want to place all of your stimulation, then you're going to direct that stimulation into a particular portion of that segment. And I also mentioned a little bit about the different types of batteries. So there's something called a rechargeable battery that actually all three companies have this available. So with rechargeable batteries, it's about maybe about 10 to 11 years of battery life potentially. And you do have to recharge your battery from anywhere from 30 minutes up to an hour per week. Sometimes people do not want to deal with the hassle of recharging their battery every week, so then you can opt for the non-rechargeable battery. In terms of other types of DBS technology or advances, so in the past few years, Medtronic has developed something called brain sense technology, which is capturing brain signals or local field potentials using the implanted lead. This is typically recording from the adjacent contacts from the one in which were currently being stimulated. And it can record simultaneously while delivering therapeutic stimulation. The clinicians often correlate these brain signals with the stimulation, as well as the patient captured events, such as medication administration, the symptoms, or potentially side effects. And most recently, Medtronic has come out with something called the adaptive DBS technology, which is actually a closed loop DBS system that records and then analyzes brain signals, allowing for a real-time, almost automated adjustment of the DBS stimulation parameters. So this is just a clinician DBS tablet, and which shows these graphs of local field potentials, or these brain signals that's being analyzed. So here you can see that at this particular time, we can actually look at these particular events that the patient has recorded, and then actually open up the graph to look in detail what exactly is happening in the brain signal at a particular event or time. Other advances in DBS technology include the Illumina programming algorithm. This is from Boston Scientific. This is a programming software that takes into account the patient's anatomy as well as the three-dimensional lead location. It uses a type of a point and click type of targeting, which is a convenient approach for clinicians, as well as using a customized stimulation field. So when we're increasing the stimulation, it actually will generate a diagram in the tablet of what is being stimulated in the brain. This type of technology can help in order to find the appropriate sweet spot a little bit faster and easier. So this is it for my brief overview of DBS. And I also want to give you some resources about the verified scientific sites that are out there that can provide you with more information about DBS. So for example, for Parkinson's disease, that's the Michael J. Fox Foundation, as well as the Parkinson's Foundation. For the diagnosis of essential tremor, that's the International Essential Tremor Foundation. And then finally, for the diagnosis of dystonia, there's the National Dystonia Foundation. And those are great websites to look into.
Following Dr. Lowe, we have Dr. Ron Alterman here. Dr. Alterman is the chief of neurosurgery at BIDMC and a professor of neurosurgery at Harvard Medical School. He was one of the first surgeons to perform DBS surgery in the US and has published over 100 articles and book chapters on this subject. So he's here to just speak a little bit more about the surgical process itself and then answer any questions that you have about DBS surgery. So I'll turn it over to Dr. Alterman now.
Great, thank you. Hi, everybody. I am, in fact, in the operating rooms. We're about to go in and take somebody's brain tumor out. So I'll be brief. I think Dr. Lowe gave a great overview. In terms of the surgery itself, I still do the operation with some minor modifications and improvements over the years, the way I've been doing it for more than 30 years. So I'll go through each of the things that I know that patients typically are concerned about. Awake versus asleep DBS, I leave that up to the patient, particularly for the Parkinson's disease targets. For instance, on Tuesday, I did a patient and she was awake at her preference, and today I did a DBS on a patient who wanted to be asleep. And so at this point in my experience, it doesn't matter. We seem to get the same results awake versus asleep. There's a little more information I can glean with the patient awake, with test stimulation in the operating room, but overall, in the long run, the results seem to be the same. I still use the stereotactic head frame, although I use the most modern one that came out a few years ago, but still made by the Electa Corporation, the Lexel frame. I still think that that's the gold standard for consistent, accurate targeting. A lot's been made of the ClearPoint navigation system that allows one to target and do the implants inside the MRI scanner. But in my experience and from what I've observed, it takes far longer to do the operation that way. You're tying up the MR scanner, and it's really not any more effective. And in fact, the people who uh, first helped develop the technology, the group at UC San Francisco, they ultimately published a paper showing that the results were exactly the same. So I can do the operation far more efficiently in the operating room with the standard head frame and an intraoperative CT scanner. Plus, it allows me to still do test stimulation, which you cannot do in the MRI scanner, which I think is a major drawback to that technique. So um, we're very efficient. You come in on the morning of surgery. We do shave your head. I think that that's best for reducing the risk of infection. It allows the sticky sterile drape to stick to your head better than having to deal with the hair. We numb the scalp and we place the stereotactic head frame, and then we go into the operating room. We then get a CAT scan of your brain inside the frame. We merge that to the MRI that we've already gotten ahead of time and upon which uh, I've planned out the surgery in terms of where I want to place the electrode and what angles of approach I want to take. And then the computer, we merge that MRI to the new CAT scan inside the frame, and the computer generates X, Y, and Z coordinates for me to set on the frame to do that. Um, and and then again, we're in the room. If you want to be asleep, you go to sleep. Otherwise, we give additional numbing to the top of the scalp. The incisions are about 3 to 4 centimeters, so a couple of inches long. They're behind the hairline towards the top of the head. So when your hair grows back, no one can see anything. We drill a small hole, and then through that, we implant the electrode. We then do test stimulation. If all of that checks out, the electrode gets locked down in position. There's a little locking mechanism that I secure to your skull, and it holds the electrode in place. And there's a cap that then covers the burr hole. We then get another CAT scan once the electrodes are in, and we merge that CAT scan to the prior scans and show that the electrode has in fact matches up to the planned trajectory, which it does 99.9% of the time, and also allows me to confirm that there's been no bleeding in the brain, which is the biggest risk of the operation. All of that looks good. We take you out of the head frame. If you're asleep, we keep going. If you're awake, we now put you to sleep, and then we put in the power pack with a pulse generator and the extension cables, and we get everything done in one day. And typically, we can get all of that done starting at 7:30 in the morning and get both electrodes in and the generator before noon. You will stay overnight in the hospital for us to observe, make sure everything's going okay, and then most patients are discharged the morning after. You come back and see me in the office a week to 10 days after your surgery. We check the incisions, take out the surgical staples, and we're done. And then we send you back to your neurologist for programming of your device. Dr. Lowe's already gone over the benefits of deep brain stimulation. The surgical risks, the main surgical risk is the risk of bleeding in the brain at the time of the electrode implant. In my hands, that risk is less than 0.5%. And the last time it's happened in my hands was 20 years ago when I was still practicing back in New York. So the risks are very, very low from that standpoint. There is a risk of postoperative confusion, which is why we have you undergo the neurocognitive assessment. If you pass the neurocognitive assessment, the risk of postoperative confusion is extremely low. And even if it does occur, it's usually very transient. More permanent cognitive decline is seen in patients that are already having cognitive issues ahead of surgery, and then the surgery can make that worse. We worry about infection. Anytime we're implanting hardware in the body, there's a risk of infection. That risk in our hands is 1% or less. And so, again, quite low. And then on the rare occasion, a battery, no, we don't have battery malfunctions anymore. In the early days, we had some, but not many. But you can occasionally have a wire break. Usually it's one of the extension cables and not one of the brain wires. So overall, we've gotten to the point we do the operation quite efficiently, as patient-friendly as we can be, and with very low complication rates and good outcomes in terms of precision of the electrodes. And with that, I'll turn it over for questions if anybody has any questions for me.
One of them is there any downside to implanting DBS too early?
No, in fact, there have been a number of studies that show that um, even earlier implants than we normally do are beneficial to patients. Um, some insurance companies might balk at doing it too soon, but no, there really is very little downside. Back when we had a somewhat higher complication rate, the argument would be you don't want to do it too soon. Why, risk a surgical complication? But on the other hand, now, as I said, um, uh, there was actually even a study called the Early Stim PD study, which showed that very early implantations are very effective and improve quality of life long term.
I was just gonna add a couple of things. It's just that we, as movement disorder clinicians, typically use that 4-year mark for Parkinson's disease. That's more to make sure that the patient doesn't have something called atypical Parkinsonism. But yeah, so the Vanderbilt group did that early STIM trial, and they have had patients as early as like 6 to 12 months after diagnosis, I believe.
No, but there was even the Schupak article from Germany, which was 3 years.
Right.
Yeah.
All right, great. Another question that came through, Dr. Lowe had mentioned several different brands or companies for DBS. How does that get decided?
Yeah, so I usually ask the patient first if they have any preferences themselves, but then we also go through a detailed discussion in our DBS monthly meeting. So factors to consider are every company has their own advantages. So for example, Medtronic recently came out with adaptive DBS system, and they have the local field potential recordings. Well, Boston Scientific, for example, has Illumina technology, which helps guide programming. And then finally, Abbott has their virtual or remote DBS programming capabilities. So every company is a little bit different, and then I can, do a more detailed chat with a particular patient about the advantages of each of them.
Another quick question. Someone asked, will the patient feel any sensation when the device is turned on?
Sometimes you'll feel a transient tingling that usually goes away, and that's fine. Yeah. But with Parkinson's in particular, you tend to leave the device on all of the time, and so no, you really shouldn't feel any tingling.
Yeah, it's usually during that initial programming visit that I would test and then increase the stimulation slowly and see where you could potentially get some DBS induced side effects, but those are again transient. If I turn the stimulation down or try a different contact or different, stimulation location, then usually the side effects will go away.
All right. And then I think the last question that I got is, how long will the DBS provide benefits?
It's been a continuous benefit for years. As far as I know, like there's studies going up to 8 to 10 years following DBS patients with Parkinson's disease over time. So it's a continued benefit. But you do have to take into account that it is a progressive disease. So that's why some conditions can worsen, symptoms can worsen over time.
Right. That's what people have to remember is we're not affecting the underlying disease progression. So you may not be doing as well 6 years down the line as you were the first year after DBS, but you'll still be better stim on versus stim off. So the stimulation itself will still be effective. It's just doing so relative to a worse Parkinsonian state. And then also, no case to follow, turnover room 16. Sorry. And then also keep in mind that the types of symptoms that we know aren't improved by DBS might become more important as the disease progresses, that being the gait disturbance and the cognitive problems. And so those become more disabling over time when they occur as the patient ages and progresses.
All right. Well, thank you, Dr. Lowe and Dr. Alterman. I know Dr. Alterman has to get into surgery, and we want to leave about 20 minutes or so for our three ambassadors here to talk a little bit about their experience undergoing DBS surgery at BIDMC. So I think Dr. Alterman and Dr. Lowe will sign off. Thank you both. All right, and I'm also going to stop the recording.